Welcome to eNormous Nephrology. This is a quick 8-session board review designed to allow you to prioritize areas needing further study as you progress towards the boards and as you progress in your study of nephrology. The first session, which is this session of 8 sessions, will be devoted to physiology. Cardiology has the electrocardiogram. Nephrology has the urinalysis. Every nephrology case study begins with a urinalysis. Urinalysis provides a wealth of information. The most important of these are hematuria and proteinuria. If the dipstick is positive for blood, this indicates that heme is present. Red blood cells in the urine sediment indicate hematuria. So if the dipstick is heme positive or positive for blood, and you do urine microscopy and you see intact red blood cells, then that is the definition of hematuria. If you do not see red blood cells in the urine sediment, then hemoglobinuria may be present, as in hemolysis, or myoglobinuria, as in rhabdomyolysis, or sometimes dilute or alkaline urine can result in lysis of RBCs. You should suspect this if the specific gravity is less than 1.01 and or pH is greater than 8. If the dipstick is negative for blood, but the urine is red, then you should consider porphyria, meat ingestion, or food dyes. Protein is another important finding that you should look for in a urinalysis. The dipstick detects primarily albumin. Normal urine has no protein by dipstick, but occasionally very concentrated urine will be trace positive for protein in healthy individuals. A positive dipstick should lead to a quantitative measurement. Classically, this is done by a 24-hour urine collection, but as creatinine is excreted at a constant rate, a urine albumin to creatinine ratio or urine protein to creatinine ratio is sufficient in most patients. Healthy subjects excrete up to 30 milligrams of albumin and 150 to 200 milligrams of total protein per day. And on average, 1,000 milligrams of creatinine per day is excreted. Thus, the normal urine albumin to creatinine ratio is less than 30 milligrams per gram, and the normal urine protein to creatinine ratio is less than 200 milligrams per gram. Urine albumin to creatinine ratio of 330 to 300 milligrams per gram is considered to be microalbuminuria, and greater than 300 milligrams per gram is overt albuminuria or macroalbuminuria, but the terms microalbuminuria and macroalbuminuria are no longer used. Urine protein to creatinine ratio greater than 500 milligrams per gram indicates overt proteinuria and should be investigated and explained. Normal urine does not contain glucose because filtered glucose is reabsorbed by the proximal tubule. Glycosuria with elevated blood glucose occurs in diabetes mellitus. If the serum glucose is normal and you have glucose in the urine, this is renal glycosuria, which can be isolated or associated with other proximal tubular dysfunction with associated findings such as phosphaturia, aminoaciduria, and bicarbonaturia. This is Fanconi syndrome. The most common cause of Fanconi syndrome is multiple myeloma, and this should be excluded, and the differential should be explored. Urine microscopy is done to look for red blood cells and to look for casts and crystals. This is the appearance of red blood cells under urine microscopy. Red blood cells are small, round, with a concave shape. This is the appearance of a white blood cell. White blood cells are small cells, usually 1.5 to 2 times larger than a red blood cell, are regularly round, colorless because they do not have heme pigment, and have a slightly grainy appearance. An analysis of the crystals should also be made. If you see envelopes, that indicates calcium oxalate crystals of the dihydrate form. The monohydrate calcium oxalate crystals are dumbbells. This hexagonal crystal is a cysteine crystal. Uric acid crystals can appear under several shapes. The classic crystals are rhombuses with more or less eroded tops. Uric acid crystals can also be needle-shaped and rosettes. When examined with a polarizing filter and red compensator filter, they are yellow and aligned parallel to the slope axis of the red compensator, but turn blue when aligned across the direction of polarization. That is, they exhibit negative birefringence. These are coffin lids, and these are triple phosphate crystals composed of magnesium ammonium phosphate. Casts provide a lot of insight into the pathophysiology of the process that is going on in kidney injury or other kidney disease processes. This is a red blood cell cast, and you can see individual red blood cells within the cast. This type of cast is seen in glomerulonephritis. This is a white blood cell cast, and white blood cell casts can indicate infection, and if there is no infection, i.e. if there's sterile pyuria, then this can indicate interstitial nephritis. This is a granular cast, and this is formed by sloughing of tubular proteins and accumulation of debris in the tubules, and the shape is in the form of a tubule. This is typical of acute tubular necrosis. This is an oval fat body, which is lipid-laden macrophages in nephrotic syndrome, and you can see the Maltese crosses in polarized light. So let's talk about microscopic hematuria. The typical differential starts with urinary tract infection, urethritis, trauma, exercise, nephrolithiasis, and if you have abdominal pain which is not otherwise explained, then you can consider loin pain hematuria syndrome. Microscopic hematuria is frequently seen in sickle cell trait if they're African American. Urethral stricture, benign prostatic hyperplasia, prostate cancer, IgA nephropathy should be considered, and we will discuss that in glomerulonephritis. Alport syndrome, thin basement membrane disease, polycystic kidney disease. These are diseases with a family history of hematuria and or kidney disease. And you should always consider renal embolism and infarction. especially if they have atrial fibrillation or congestive heart failure. And if they're smokers, then you should definitely consider cancer, such as prostate cancer, bladder cancer, or renal cell carcinoma. Just like nephrolithiasis can cause microscopic hematuria, crystalluria can cause hematuria, and specifically you should look for calcium crystals or uric acid crystals. Other types of crystals may be much less common. I will put a question into my presentation. It will be interspersed throughout the presentation just to stimulate thinking so that it's not just facts and details, but a thinking exercise as well, and somewhat fun in that way. A 57-year-old man is seen for evaluation of microscopic hematuria detected by his primary care physician on a routine screening urinalysis. The patient denies any medical problems, including any alteration in urinary output, pattern, or color. He takes no medications. Physical examination shows him to be normal tensive. The rest of the examination is normal. Laboratory studies revealed the following: blood urea nitrogen 16 milligrams per deciliter, creatinine 1.2 milligrams per deciliter, urinalysis 15 to 20 red blood cells per high power field, and these are isomorphic, not dysmorphic. Dysmorphic red blood cells indicates that the red blood cells have traversed through the glomerular basement membrane and have been modified through that process. Trace protein, no casts were seen. Which one of the following imaging studies would provide the most sensitivity and specificity in evaluating this patient for a uroepithelial neoplasm? Computed tomography urogram, intravenous urogram, magnetic resonance urogram, or Doppler ultrasound. The correct answer is computed tomography urogram. In patients with microscopic hematuria with normal morphology of red cells, the risk of malignancy is reported to be 2 to 12%. IV urogram has a lower sensitivity than CT urogram for detecting renal masses smaller than 2 to 3 centimeters, making option A the best answer. Although the relative sensitivities of the CT urogram and intravenous urogram for detecting urothelial neoplasms is still a subject of investigation, there has been a shift to using CT urogram, as it appears to be a more comprehensive examination which may be more sensitive and specific than intravenous urogram. MR urogram is equivalent to CT urogram in detection of renal masses, but small urothelial lesions in a non-dilated collecting system are not detectable on MR urogram. Doppler ultrasound is useful in evaluating the renal vasculature as well as vascularity of a renal mass, but the collecting system cannot be evaluated by this technique. Let's talk about proteinuria. Urine albumin and or urine total protein can be measured. The urine dipstick for protein is a screening test. It's semi-quantitative, reacts primarily to albumin, and is affected by urine concentration. Classically, the urine total protein was assessed by the addition of sulfosalicylic acid to the specimen, which precipitated total protein and increased turbidity of the urine. So you could compare albuminuria to total protein in the urine. Urine total protein is now more commonly measured by dye-based assays, which react predominantly to albumin, but also to a lesser extent to globulins, including monoclonal paraproteins. Thus, a disproportionate increase in urine total protein relative to urine albumin suggests possible paraproteinuria. There are three types of processes that can cause proteinuria: glomerular proteinuria, tubular proteinuria, and overflow proteinuria. Generally, protein or albumin is too big to be filtered by the glomerulus. So you would expect glomerular damage if you see protein in the urine. Glomerular damage can be transient or persistent. Also, processes that cause hyperfiltration, such as congestive heart failure, fever, or exercise, or acute illness, can cause glomerular proteinuria, and this is generally transient. If you have tubular damage, then you can have impaired tubular reabsorption, such as light chains, or you can have excretion of enzymes from damaged tubular cells. Overflow proteinuria occurs in situations in which large concentrations of small proteins, such as light chains, hemoglobin, or myoglobin, are produced and freely filtered by the glomerulus. These filtered proteins overwhelm the capacity of the renal tubules to completely reabsorb and catabolize these proteins, so they appear in the urine. Now, let's talk about glomerular filtration rate. How do you measure glomerular filtration rate? Plasma creatinine is the most commonly used method. It's an indirect measure of glomerular filtration rate. The plasma creatinine concentration will reflect both the production rate of creatinine, which is proportional to muscle mass, and the excretion rate of creatinine, which depends on renal function. In the steady state, that is when plasma creatinine is stable, production equals excretion. This equality is also true when there's chronic kidney disease, although there will be a higher level of plasma creatinine, which will be inversely proportional to glomerular filtration rate. The earliest studies that described the calculation of glomerular filtration rate was the Cockcroft-Gault equation. That has essentially been replaced by the MDRD and CKD-EPI. The problem with the MDRD is that it did not include non-Caucasians and diabetics. The CKD-EPI included a much broader population of patients and is the most widely used equation in use. Serum cystatin C is produced by all nucleated cells. It has a constant production rate. However, it's filtered and completely reabsorbed. So even though you can calculate glomerular filtration rate, clearance measurements cannot be made. The benefits of cystatin C is that it's less influenced by gender, age, or muscle mass. Negatives are that it's affected by diabetes, thyroid, inflammation, and fat mass. In the pediatric population, the CKID U25 equation has been used and produced via population studies, and the CKID U25 equation has been proven to be better than the CKD-EPI in the pediatric population. This calculator is available on the internet. Let's talk about the anatomy of the kidney. This is what a kidney looks like. You have an outer cortex, an inner medulla, the calyces, and the renal pelvis, which converges into the ureter. And at a microscopic level, you have the nephron. You have the afferent artery, which gives rise to the glomerulus. The blood is filtered. The filtrate goes through the proximal tubule, down the descending limb of the loop of Henle, up the ascending limb, through the distal convoluted tubule, and through the collecting duct into the ureters. As you can see, the distal convoluted tubule kind of winds around and is adjacent to the glomerulus. And that's important when we talk about tubulo-glomerular feedback. This is the macula densa, and the macula densa is present at the junction of the distal convoluted tubule and the glomerulus. And the macula densa has the sodium-potassium 2-chloride channel, which we all know is acted upon by the loop diuretics. The sodium-potassium 2-chloride transporter, of course, as we all know, is present in the thick ascending limb of the loop of Henle. It has a major function in the macula densa as well. Salt is sensed by the NKCC2. Low sodium in the macula densa stimulates prostaglandins. Prostaglandins cause increased renin and activation of the renin-angiotensin-aldosterone system. High distal tubular sodium chloride induces afferent arteriolar vasoconstriction. Low tubular sodium chloride induces renin release. The loop diuretics block the NKCC2. There is decreased entry of sodium into the macula densa cells, increased prostaglandin, and increased renin release. Medication effects can also be important and sometimes work through the tubulo-glomerular feedback. The most important of these and commonly known of these is amphotericin, which causes increased permeability of the macula densa cells and causes afferent arteriolar vasoconstriction and a fall in GFR. Let's talk about the interstitial medullary gradient. The filtrate passes through the proximal tubule and into the descending limb of the loop of Henle, where water is reabsorbed. And we'll talk about how water reabsorption is driven by maintenance of the interstitial medullary gradient. The thick ascending limb of the loop of Henle is impermeable to water, and there's active transport of sodium chloride into the interstitium, maintaining an interstitial medullary gradient. And this provides a gradient for absorption of water by the descending limb of the loop of Henle. As the filtrate passes through the collecting duct, water is absorbed by the action of antidiuretic hormone, which causes insertion of aquaporin channels into the membrane of the cells of the collecting duct. In the distal collecting duct, urea passively moves into the interstitium, also creating a gradient and drive for water reabsorption via the distal descending limb of the loop of Henle. The vasa recta countercurrent medullary transport will transport water away into the circulation and will result in maintenance of the interstitial medullary gradient, and so that the medullary interstitial gradient is not dissolved and that water transport can occur continuously. Quick synopsis of tubular function. The proximal tubule reabsorbs the bulk of solutes and water filtered by the glomeruli. The loop of Henle actively reabsorbs electrolytes such as sodium, potassium, and chloride. The thick ascending limb of the loop of Henle is impermeable to water, allowing formation of dilute urine. The distal convoluted tubule and collecting duct fine-tune sodium excretion and regulate potassium and acid-base balance. In the absence of antidiuretic hormone, the collecting duct is also impermeable to water, allowing excretion of dilute urine. Antidiuretic hormone increases water permeability in the collecting duct, allowing urine concentration. Now let's go to the thick ascending limb of the loop of Henle. And here you see that the sodium-potassium 2-chloride transporter will move sodium and potassium and chloride across the luminal membrane into the cell of the thick ascending limb of the loop of Henle. Subsequently, sodium is conserved via the sodium-potassium ATPase. The ROMK channel functions to excrete potassium into the lumen, and the calcium sensing receptor actually blocks the ROMK channel so that potassium is not excreted. There's less positive charge in the lumen and less passive absorption of calcium into the interstitium. The calcium sensing receptor reacts to the presence of calcium, so it makes sense that in the presence of calcium, passive absorption of calcium should be minimized. You have the sodium chloride co-transporter in the distal convoluted tubule. The sodium and chloride electrolytes are transported across the luminal membrane into the cells of the distal convoluted tubule. Subsequently, the sodium is conserved via the sodium-potassium ATPase. And the sodium-calcium exchanger allows for conservation of calcium. Proximal tubular dysfunction leads to a characteristic disorder called Fanconi syndrome. Failure to reabsorb glucose, phosphate, bicarbonate, potassium, amino acids, and low molecular weight proteins such as beta-2 microglobulin filtered by the glomeruli leads to renal glycosuria, which is in the presence of normal plasma glucose, phosphaturia with hypophosphatemia, metabolic acidosis, which is proximal renal tubular acidosis, hypokalemia, aminoaciduria, and tubular proteinuria. Isolated proximal renal tubular acidosis can also occur. Loop of Henle dysfunction leads to Barter's syndrome. And here I think of bloop, as in blooper. Barter's leads to a dysfunction of the NKCC2, which is acted upon by the loop diuretics. So Barter's is loop diuretics. It's characterized by salt wasting, hypokalemia, and metabolic alkalosis. Hypomagnesemia is mild and hypercalciuria is present. So Barter's syndrome is an abnormality of the NKCC2 at the level of the ascending limb of the loop of Henle. In distal convoluted tubular dysfunction, you have Gitelman syndrome, which is basically an abnormality of the sodium chloride co-transporter, which, as we know, is acted upon by the thiazides. So Gitelman's is like having constitutive thiazides on board. This is characterized primarily by hypokalemia, hypomagnesemia, hypocalciuria, and it also causes hypomagnesemia, which is much more severe in Gitelman syndrome than in patients taking thiazides. Let's do a quick question. Several members of a family have hypokalemic metabolic alkalosis. Which of the following, if present in all of the affected patients, would most strongly favor the diagnosis of Gitelman syndrome? Hypercalciuria, hypomagnesemia, hyperuricemia, presentation in early childhood, or presence of severe muscle weakness. Barter's syndrome is frequently diagnosed in childhood. Gitelman's can frequently be diagnosed in older patients. Gitelman's is characterized by hypocalciuria, just like thiazide diuretics are characterized by hypocalciuria. Hyperuricemia is present in 50% of patients with Barter's syndrome. Gitelman syndrome is caused by mutations in the SLC12A3 gene, which encodes for the thiazide-sensitive human sodium chloride co-transporter. This can lead to renal underexcretion of uric acid, which can cause hyperuricemia. Gitelman syndrome is an autosomal recessive, salt-losing tubulopathy characterized by renal potassium wasting, hypokalemia, metabolic alkalosis, hypocalciuria, hypomagnesemia, and hypereninemic hyperaldosteronism. Therefore, the best answer is hypomagnesemia. Let's go to the collecting duct. Here you will see the ENaC channels, which is acted upon by aldosterone to cause conservation of sodium. And here you can see the sodium move across the luminal membrane into the principal cell of the cortical collecting duct and subsequently conserved by the sodium potassium ATPase. And here also you have the ROMK channel, which excretes potassium. Just a little bit more detail on the calcium sensing receptor. The calcium sensing receptor, as the name implies, senses calcium, and in the presence of calcium at the level of the thick ascending limb of the loop of Henle, it will block ROMK channels. So potassium is conserved by the NKCC2, excreted by the ROMK channel. Calcium sensing receptor in the presence of calcium blocks ROMK. There's less excretion of potassium, less positive charge in the lumen, less passive absorption of calcium. At the level of the distal convoluted tubule, presence of calcium will block transport of calcium across the luminal membrane, resulting in lesser absorption of calcium, and the presence of calcium will ultimately lead to blockage of release of parathyroid hormone. Let's talk about renal tubular acidosis. There are two types of renal tubular acidosis. If it occurs in the distal tubule, it's called type 1 renal tubular acidosis, and this is characterized by inability to excrete protons, so the urine pH will be high. In type 2 and type 4 renal tubular acidosis, the pH is generally less than 5.3. In proximal renal tubular acidosis, bicarbonate is lost in the urine, and urine pH may initially be high, but as metabolic acidosis ensues, the urine pH will fall to less than 5.5 and typically less than 5.3 as the plasma bicarbonate concentration decreases. Type 4 renal tubular acidosis is hypoaldosteronism, typically seen in diabetes. What happens is that prorenin is glycated, and this effectively leads to a state of hypoaldosteronism, hyperkalemia, and in this type of renal tubular acidosis, the urine pH is usually appropriate for serum pH, usually less than 5.5, when there is a metabolic acidosis in the serum. Let's talk about urine sodium and urine chloride. This can provide lots of insight into the pathophysiology of what's going on in the patient. Usually, so urine sodium and urine chloride will go in the same direction. If the urine sodium is high and the urine chloride is low in the setting of volume depletion, this suggests a non-reabsorbable anion, typically bicarb, and the pH is generally 7 to 8. If the pH is less than 6, this may suggest other anions are present in the urine, such as ketoanions and ticarcillin, piperacillin, carbenicillin, and other anions. In this scenario, increased aldosterone leads to metabolic alkalosis of kidney origin. If the urine chloride is high and the urine sodium is low in the setting of volume depletion, this suggests a urine cation, typically an ammonium cation, which is lost in the urine and causes concurrent loss of urine chloride. This is typically seen in metabolic acidosis due to diarrhea. Let's end with a very important slide. These are 5 typical scenarios, and you will see these on the boards. You'll see there's a scenario of acute vomiting, chronic vomiting, remote loop diuretic, chronic loop diuretic, and chronic diarrhea. And these have signature electrolytes in the urine. In acute vomiting, you will have metabolic alkalosis because of loss of hydrochloric acid in the vomitus. The ensuing metabolic alkalosis leads to elevated bicarb in the serum, subsequent bicarbonaturia, and obligate losses of potassium in the urine. The urine sodium is conserved, and the urine chloride is actually low because the bicarbonate is being lost, and the chloride will be conserved to maintain electron neutrality. In chronic vomiting, essentially you have a state of volume depletion. Aldosterone will be released. You will conserve sodium and chloride, so the urine sodium and urine chloride will be low. Aldosterone will also cause metabolic alkalosis at the level of the kidney, so your urine bicarb will be low, and in the setting of chronic vomiting, you'll have total potassium depletion, so your urine potassium will also be low in order to conserve potassium and prevent potassium loss. In the setting of chronic loop diuretic, again you have aldosterone release, metabolic alkalosis at the level of the kidney, conservation of sodium bicarbonate. You will have loss of ammonium chloride, which is why you see increased chloride in the urine, and again you will conserve potassium because of a total potassium deficit in the body. In chronic diarrhea, you will have aldosterone release, conservation of sodium bicarbonate, loss of ammonium chloride, and conservation of potassium. In the remote loop diuretic scenario, you will have loss of sodium chloride in the urine, as well as potassium excretion in the urine because of the effect of the loop diuretic. Please like and subscribe by clicking below. Comments, suggestions, and questions are welcome and appreciated. I hope you enjoyed the talk. Please come back for the next session, the second of 8 sessions of our quick board review, which will deal primarily with potassium and sodium. Thank you very much.